Hello and welcome to another emergency questions and answers for families in intensive care and intensive care at home. Thank you so much for joining the live stream today, and also thank you for those of you watching it on replay. We will be going for about an hour where I answer any of your questions. You can join me live on the stream here, and I will put the StreamYard link in the chat pad. It is here, or you can type your questions into the chat pad. But to get your questions answered most efficiently, it's easiest if you just join me here live and you can talk to me. You don't have to go on camera, but it's up to you, of course. So before we go into today's questions, what makes me qualified to answer questions for families in intensive care and intensive care at home? Again, my name is Patrick Hutzel. I'm the founder of intensivecarehotline.com and also the founder and managing director of intensivecareathome.com. With Intensive Care at Home, we are providing consulting and advocacy for families in intensive care, and we have been doing so since 2013. With Intensive Care at Home, we are providing a genuine alternative for long-term ventilated adults and children to leave intensive care. We are basically sending intensive care nurses into the home to provide a genuine alternative to a long-term stay in intensive care. Now, I have worked in critical care nursing for nearly 25 years in 3 different countries, where I worked as a nurse manager for over 5 years, and I have been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And I can say without any exaggeration that we have saved many lives with our consulting and advocacy, and you can look that up on our testimonial section as well as on our podcast section at intensivecarehotline.com, where you can see some client interviews. With Intensive Care at Home, we are currently operating all around Australia and all major capital cities. And like I said, we are, and as well as in regional and rural areas, we are location independent. We are accredited for intensive care at home nursing. We provide a genuine alternative for long-term intensive care patients, whether that's with tracheostomy, ventilation, whether it's BiPAP, CPAP ventilation without a tracheostomy, whether it's tracheostomy without ventilation, and also home TPN, home IV potassium, home IV magnesium, palliative care at home, ventilation weaning at home. We've also sent our critical care nurses into the home for emergency department bypass services. And we have done so successfully for the Western Sydney Local Area Health District as part of their In Touch program. With Intensive Care at Home, we're also providing Level 2 and Level 3 NDIS support coordination. Now, without further ado, let's go to the first question. And the first question today comes from Henry. And Henry says, "Hi, Patrick. So I have my dad in ICU. He was in there for basically liquor poisoning. He was put on the ventilator and sedation, and he was taken off the first time, and he was having a bit of what I think was delirium, and then he was doing fine. Then caught pneumonia, and then they found him unconscious, and he got his breathing back. They got him stabilized, and he was on the ventilator again. And at times he will blink or move his eyes, but the doctors said he will never wake up again." Well, I find that very interesting for the doctor to say, Henry, without giving you more information. Now, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. And they don't know how to manage doctors and nurses in intensive care. And Henry, that is exactly what you're up against here. You just don't know what you don't know. First off, Research 10, 15 years ago suggested that approximately 90% of intensive care patients survive intensive care and leave intensive care alive. That's 9 out of 10 patients surviving. Okay, doesn't talk about quality of life, doesn't talk what their life looks like in 6 weeks' time, in 6 months' time, in 6 years' time. Doesn't talk about that, but there's a very good chance your dad will leave intensive care alive. Now, I've seen recent research, once again, same statistics, approximately 90% of intensive care patients survive, and that's with the population getting older in general, right? So keep that in mind. Now, you haven't shared how old your dad is, you haven't shared that, right? But to break things down for you, okay, your dad is on a ventilator, sedated, he's probably got some opiates going in, right? And he's delirious. Okay, now he's got a pneumonia, they put him back in an induced coma again, he's on the ventilator, Well, what needs to happen here next is they need to take him off sedation once the pneumonia has been cleared, and they can clear the pneumonia hopefully by giving antibiotics, antivirals, antifungals, depending on what infection he has, right? Optimize ventilator settings, check up with arterial blood gases, maybe do a bronchoscopy. And then once the pneumonia is healing and cleared, wake up your dad and wean him off the ventilator, and extubate him. Extubation means the removal of the breathing tube, right? So for the ICU doctor to say your dad will never wake up without telling you why is, well, I argue very unethical, right? It's not the right thing to do without giving you more information. Now, when he says your dad isn't waking up or will never wake up, where's the evidence, right? So what evidence would you need? Well, you would need evidence such as a CT scan of the brain, an MRI scan of the brain. You would need evidence such as an EEG of the brain. You would need evidence such as a neurology consult, right? I mean, other than that, it's just a statement, right? Has your dad had a stroke? Has your dad had a hypoxic brain injury? Has he had seizures? You haven't mentioned anything like it. Once again, the biggest challenge for families in intensive care is that they don't know what they don't know, right? So, that's just the reality. You need to understand of what's really happening. And I'm glad you're reaching out. What you need to do next, is get access to the medical records. Contact me again so I can talk to the doctors and nurses directly, or I can set you up with questions to ask on top of what I'm sharing here, But the best questions to ask is when you look at medical records and when you look at the things that are happening in detail. When someone is critically ill in intensive care, Henry, there's dozens and sometimes hundreds of things happening simultaneously. And unless you look at these details, with a very close eye, you can't connect the dots, right? You can't connect the dots. And it takes years of studying, training, clinical exposure to connect the dots, right? You are just scratching the surface here with your questions. And it's good that you're asking, of course, but again, for the doctor to say your dad will never wake up, that's just a statement. And you will need to get the evidence, which it's not difficult to get by getting access to the medical records, and then we can review them for you. Or like I said, one of the shortcuts is for you and me to talk to the doctor directly, right? So I hope that helps you understand what you need to do, right? Once again, approach it with that 90% of intensive care patients survive, right? So why would your dad not survive? Why would your dad not survive? Right? If 90% of intensive care patients survive, no reason why your dad won't survive. Okay, so let's keep it moving, and let's get on with the next question. And again, if you have questions, type them into the chat pad or join me live on the StreamYard link here that I posted in the chat pad. Let's get on to the next question from Crystal. Hi, Patrick. My mother-in-law has been in ICU since her stroke 10 days ago, on a ventilator, breathing tube and sedation. They say she's brain dead and working on a brain stem, that she has strong lungs and a strong heart. They shut off her ventilator but just used a little pressure the day before yesterday to show us her lungs were strong. They shut off her ventilator but just used a little pressure the day before yesterday to show us her lungs were strong. Okay, so they put her in a CPAP or pressure support mode, which also means that she's not brain dead. If someone is showing signs of breathing efforts, they can't be brain dead. So I can't believe, and I'm sorry, this is a long email, but I have to stop here because I can't believe how many families in intensive care contact us and say, oh, I've been told my loved one is brain dead. And then when we look at the details, when we dig deeper, when we ask all the right questions, then we find out, oh, your loved one is breathing. Well, they can't be brain dead. So clearly, intensive care teams are misleading families to push their agenda. And what's their agenda? Is to empty ICU beds as quickly as possible in most cases, right? And by telling families, well, your loved one is brain dead, there's nothing we can do, which often is not true, right? That's when it gets very difficult. For families, they believe everything they've been told. And please keep in mind, what you see is not what you get. You have to ask the right questions. And you can't take things for face value. It brings me back to 90% of intensive care patients survive. You have to question everything. You have to question everything, right? You are in a once in a lifetime situation that you can't afford to get wrong, right? So also, when it comes to brain death testing, right, it has to be done by two independent parties, by two independent doctors, and they have to both find, when they go through this rigorous testing, that brain death is confirmed. Okay, you can't just take for gospel when ICU tells you, oh, your loved one is brain dead. Where's the evidence? Similar to Henry's email a minute ago, where's the evidence that his dad will never wake up? It's just a statement. It's not reality. It's just words. Right? So let's keep it moving with Crystal's email here. So they shut off her ventilator, but just used a little pressure the day before yesterday to show us her lungs were strong. Okay, good. That means she's not brain dead. Full stop. I asked why not, and sorry, there's one other thing. There is no correlation between someone being brain dead and brain damage. There is no correlation between the two. If someone is being brain dead, they're not doing anything. Their brain is dead. If someone is being brain damaged, the brain is damaged, but they're still doing things, even though it might be minimal. But there's a big difference between someone being brain damaged and brain dead. In most jurisdictions, when someone is brain dead, they're also legally dead in most jurisdictions. Now, again, I am not putting any judgment on this, what you think about when someone is brain dead, that they should be legally dead. I'm not putting any judgment on this. I'm just telling you what the law says in most cases. And I can tell you there have been cases where that has been challenged too, that just because someone is brain dead, families objected that they're legally dead. It's all in the eye of the beholder. Okay. So they shut off her ventilator, but just used a little pressure the day before yesterday to show us her lungs were strong. I asked, why not then take her off the ventilator and let her wake up? And they say they don't know if she can swallow or cough. I said, well, can't you tell that after you let her wake up? Then they responded, we can't risk that because she has a little mucus and she might get a pneumonia. So they would have to put a tracheostomy in directly. So my father-in-law agreed to let them put in the tracheostomy on Monday. So they will then take her off sedation. He has been up there every day, not leaving. Okay, let's just stop there. Let's just stop there. Then they respond, we can't risk that because she has little music. Yeah, so here's my take on that. You could do a trial, extubation, right? You could absolutely do a trial extubation. and then see whether she can swallow or not. I don't see the need for doing a tracheostomy right away. You can do swallow assessment once your mother-in-law is off the ventilator. Okay, so just keep that in mind. So, but she has a tracheostomy now. At the beginning, they guaranteed us that she will have no quality of life and think about whether we should take them to do stuff to save her, and there was no turning back once they did. There were no turning back once they did. She will have no, at the beginning, they guaranteed us that she will have no quality of life. What is quality of life? What is it? Quality of life means something different to you than it means to me. So who are intensive care teams to make judgment about quality of life? Is that why they went into medicine or into nursing, to make judgments about quality of life? Their job should be to get the best outcomes for patients and for families. That should be their job, not make judgments about subjective, perceived experiences, because that's what quality of life is. It's a subjective experience. It's not an objective experience. Okay, so then they still say she's brain dead, but there is no way that a patient, when they finally let them wake up a little, starts biting the ventilator tube. Yeah, if someone bites the ventilator tube, they are not brain dead. Moving her arm up and grabbing the ventilator tubes again. If someone is doing that, they're not brain dead. If someone is brain dead, they're not doing anything whatsoever. Nothing, zero. No reflexes, no nothing. She shows grief on her face, uses her tongue to flick out the mouth guard, and opens her eyes and follows the doctor's voice before they put her back under sedation quickly. Well, you mentioned that she has a tracheostomy. They shouldn't put her on sedation at all. If someone has a tracheostomy and they're not fighting against the ventilator, they're not in pain, take it all off. Let them wake up, let them be weaned off the ventilator as quickly as possible. Very important. So she opens her eyes and tries to start crying when he comes up and rubs her head and talks to her, when she fights the fentanyl and propofol to try and wake her up. Is there a way for her to show them she can swallow or cough? Will her very little amount of mucus give her pneumonia that quick so we cannot let her wake up to see what she can do? Yeah, those are very, very good questions, Crystal. Now, again, I argue if she's breathing spontaneously, if she's breathing in CPAP, if she is having a clear chest X-ray, if she is having good arterial blood gases, and she's obeying commands, let's take her off the ventilator. Let's give it a trial extubation. Now, here's another thing that you can do. If she's breathing spontaneously, right, get the cuff down. So what I mean by that is the ET tube is blocked with a cuff, with a balloon. Let's take that cuff down, open up the airway by getting the cuff down, and then see whether she's potentially swallowing saliva into the lungs, because she will cough pretty quickly, most likely. That's another check you can do. So there is a way. It's not ideal, but there is a way to do that. And then if she can swallow, take out the tube, right? Sit her up, do physical exercises, physical therapy, and so forth, and hopefully she can stay off the ventilator. Okay, let's carry on. Will her very little amount of mucus give her pneumonia that quick so we can let her wake up to see what she can do? Yeah, I just explained that. I don't want her on the tracheostomy if she doesn't need it. My father-in-law is so frazzled. They did mention about sending her somewhere for therapy after she gets the tracheostomy. Right. So now we're talking. So what I mean by that is, okay, I understood that your mother-in-law already has the tracheostomy, but that's not the case. Okay, she doesn't have the tracheostomy yet. So, you know, one of the questions that you should be asking early on when you have a loved one critically ill in intensive care, one of the questions you should be asking early on is, especially if your loved one is on a ventilator with a breathing tube, what is the intensive care team doing to to get her off the ventilator and remove the breathing tube? That is one of the first questions you should be asking, right? And then see what they say. What is the intensive care team doing to avoid the tracheostomy, right? And get your family member breathe spontaneously without a ventilator and so forth. So also, this is probably where you know, an LTAC comes in. So I know that, Crystal, that you are in the US. I know that. I can see that from your email. So one of the things that you keep in mind, especially if you're in the US, if she ends up with a tracheostomy, yes, they will want to send her to LTAC as quickly as possible. Avoid that at all costs. You know, and that's often the agendas of ICUs in the US in particular. Do a trach, do a PEG, send patients onto LTAC as quickly as possible, out of sight, out of mind. It's dangerous. You know, there's enough case studies on our website at intensivecarehotline.com where, you know, ICUs in the US are pushing patients out to LTAC prematurely, unsafely, and it's unsafe. And then patients bounce back into ICU in no time and things go from bad to worse. You need to avoid that at all costs, right? You need to avoid that at all costs. So brings me back to, what do you need to do? Well, ask your loved one, ask the ICU, what are they doing to avoid the tracheostomy at all cost? Get your loved one off the ventilator at all cost. That is the question you need to ask. And I've written an article and made a video about it, how to wean a critically ill patient off the ventilator and the breathing tube. If you type that into our search box at intensivecarehotline.com, you will find the answer there. So I hope that answers your question, Crystal. Helene, nice to see you again. You're saying brain dead or trying to cover up malfeasance, personal injuries, malpractices. Yeah, could be as well. Could be as well. You know, I can't tell you, we're almost getting approached every week by families who said, oh, my family member is brain dead, right? And then when we ask the questions, it turns out they're not brain dead. You know, and that's probably only a small proportion of families that get told their loved one is brain dead. The minute we dig deeper, right, things are not happening, you know. So it all comes down to asking the right questions. It all comes down to getting professional help, you know, understanding what you don't know, right? So, Helene, medical provider said Emery lied to me that my mom was brain dead to get me to consent to pull the plug, knowing she would have passed. Sure, happens all the time. But here is another thing, Helene. If someone is brain dead, let's just say someone is brain dead, and they're really brain dead, they meet all the criteria. Once again, in most jurisdictions, US, Canada, Australia, UK, New Zealand, someone is legally dead. So whether you object to it or not, by law, they are dead. And like I said, there have been cases where that has been challenged in court as well, right? So, you know, there are cultures out there and religions out there who, you know, don't agree with that. Again, I'm not here to make a judgment. I'm just presenting the facts, you know. Okay, so yeah, terminology matters a lot in ICU, but it's also a case of terminology, but it's also a case of you doing your research. You know, you have to take full responsibility for everything that's happening. You know, you can't be going into a situation like that blind, thinking that things will miraculously change for you. It's not going to change miraculously for you, right? Okay, so let's get on to the next question. Oh, can't find the next question now. Or if you have a question in the meantime, you know, type your question into the chat pad, or, you know, join me live on the StreamYard link here. One way or another is fine. Okay, here it is. Oh, why can't I find this? I'm so sorry. Okay, now, Crystal, this is a follow-on an email from Crystal. So thank you so much for your assistance. Obviously, we're in contact with Crystal. I got back up here today with my mother-in-law and things have gone crazy. They told me that she can't do anything, that she just lays there. They cancelled her neurologist review. They told us that she's not going to do anything. There is nothing left for them to do. They are going to ship her basically to a nursing home. I asked them about the drugs, not letting her do anything, and they shut off all the drugs and they're not planning on turning back on. But the fentanyl is she gets in a little pain. I believe to show me she is a vegetable. I believe they show me she's a vegetable. She's trying to wake up now. It's been about 10 to 15 minutes. She's trying to open her eyes up and her face gets upset. And we tell her to try to stay calm while she's waking and not get upset because they need to see her do some commands. I got the medical record portal set up for her from Crystal. Okay, so it's very confusing to me what you're saying here, but on the one hand, they're telling her she's a vegetable. I think it's a terrible term being used in regards to people, right? I don't think anyone should be labeled a vegetable. That is a terrible term to use, and it should be banned from the medical and nursing community. That is my personal view. It's not a good term to use. So, of course, she won't wake up if they're still giving her fentanyl. So, fentanyl needs to be stopped, right? And if she's trying to wake up, that's a good sign. If they stop the fentanyl, hopefully she can wake up further, right? So, and if she's trying to open her eyes, that's a very good sign. And it further confirms that what we talked about last time in her last email, that she, in her last email, that she's not brain dead, right? Definitely not brain dead. So, and they need to see her to do some commands. Right, okay, great. So here's how you get your mother-in-law to wake up even further. So stop the fentanyl, start physical therapy, get her out of bed, all possible. And that's when things usually improve. Maybe a slow road to recovery, right? You got to be patient, but nevertheless, it'll be worth your while, and don't believe things about, patients being brain dead. Most of the time it's not true. Very few patients are brain dead. There are some, don't get me wrong. There are some, but very few patients are brain dead. Now, let's move on to some other questions. If you have questions, type them into the chat pad or comments, or join me live on the StreamYard link here. I'll just post the StreamYard link here once again. You can talk to me live here. All right, let's go back to other questions that have come in. I just need to bring them up on my phone. Now, here is an email from Heather who says, "Hi, Patrick. This is actually a client that we worked with on and off. I sent the URL and password for his stay in this hospital before being sent to this LTAC." So client who's got their father in LTAC. Very interesting story. So again, US-based client. The problem is that he was not on a ventilator then. He aspirated in this LTAC and then needed to be put on a ventilator there. He was on it for 3 weeks. Then he had the tracheostomy procedure. That was in February. So this is a while ago. It's just sort of, just a good case study. That's why I want to bring it up. He was on it for 3 weeks. Then he had a tracheostomy in February. He has progress to doing the TPs, which basically the TPs is a ventilation, a tracheostomy mask or a tracheostomy TPs. So basically for someone breathing spontaneously. The day after that, after the operation, his blood pressure and heart rate shot up in the evening. So operation, she means the tracheostomy procedure. The nurses called the doctor and cardiologist, and the levels brought down with medications. Now he's back on low dose of aspirin and blood pressure medication. Blood pressure had not been high since before his hospitalization for suspected COVID in December. He was treated for that only, and we found out later that no wound dressing was changed and wounds were reinfected, causing him to be readmitted to a different hospital 3 days later with septicemia. He has had periodic bouts of elevated heart rate, up to 165 beats per minute, and they have given him either lorazepam or morphine, depending on whether they think the heart rate is related to pain or anxiety. Yeah, that makes sense. Lorazepam would be for anxiety, and morphine would be for pain. My father was able to use the Passimure valve yesterday and verbalized that he was in pain and his throat hurts, but he only has the valve during speech therapy for now. He was supposed to see a foot and ankle surgeon for a consult on Friday, but they didn't show. He is being seen by infectious disease doctor and wound care. They have bumped up changing dressings on his right heel to daily. I was able to purchase some printouts of doctor orders only up until the 20th of February, and I received them yesterday. The office has now told me they will not give us access to anything else, that they consider records, nurses' notes, procedure notes, doctor's notes, and so forth, until my dad leaves. I will try to go through the huge stack of paper I was given yesterday to see the most recent diagnosis and medications. Now, what is really important for you to understand here is that, our client's dad should have never gone to LTAC to begin with, but that was before we engaged with them. This is what happens in LTAC. People aspirate. LTACs are simply not equipped to look after critically ill patients, and this is what's happened here, right? At least now it's making progress with the TPs and the T-bar, but, there's still a lot of ground that needs to be covered there. Also, he's been getting pressure sores, and again, that should never happen. That is negligence. In terms of access to medical records, well, getting access to medical records is a right, not a privilege, right? My recommendation, if someone you can't get access to the medical records, my strong recommendation is that you put pressure on and that you put a deadline on. Once again, it's a right, not a privilege. We have never had a client who can't get access to the medical records, never. Right? So it is critically important that you exercise your rights and that you don't give up, that you give them deadlines, and that you say that we need access to the medical records tomorrow by 5 o'clock. I'll tell you something. If ICUs are making it difficult to access medical records, think about this. Let's just say your loved one's case is going in front of a court, right? Let's just say that's the case. And let's just say the court says we need access to the medical records now. Do you think the hospital will withhold getting access to the medical records to a court? Think about that. Always bring it back to common sense. Always bring it back to common sense. Would the hospital be able to deny access to a court? Well, you know the answer. They wouldn't. They wouldn't. Okay, so always approach every interaction with common sense. If ICUs tell you tomorrow at 3 o'clock, we are going to take your loved one off life support and they will die, and you object, is that common sense? Can they just do that? Can they just take a life without your consent? Think about that. End of life in a hospital does not happen in a vacuum, even though ICUs love to pretend we can do whatever they want, including killing people whenever it suits us. Right? Always bring it back to common sense, please. Okay, let's go to the next question. Hi, Patrick. My father has a foot wound on his heel that was previously surgically drained, biopsied, and debrided and treated with IV antibiotics. He had a wound vac, and then the wound was dry, nothing growing in the cultures that were taken. He was transferred and finished his course of IV antibiotics for a blood infection. When I noticed the foot bandage was not being changed or checked each day and asked the nurse about it, she showed me that her directions were to only change if the bandage appeared dirty or there was a bad smell coming from it. I spoke to doctor and got assurance that the wound care physician was changing the bandage every 2 days and monitoring it because they didn't want to disturb new skin growth. We were assured there was no infection, no drainage, and no need for it to be escalated to a surgical consult. Then the wound care doctor met with me and my mother alone and said the wound doesn't look good and part of it looks soft and they will debride, but probably can't handle this type of wound and someone else will need to. And the doctor made a chop motion. So they're probably referring to an amputation here. That was right after a family meeting where they assured us he would have access to a foot ankle surgeon if needed and that wound care was communicating with the infectious disease doctor. I can't now take my father to see his podiatrist, foot ankle specialist surgeon, because after entering this LTAC and aspirating getting pneumonia, he needed to be put on a ventilator and then finally had a tracheostomy surgery and is in the process of weaning. That is going well. He is breathing on CPAP for about 7 to 8 hours per day at a very low pressure rate, and respiratory therapy has recommended that he starts on the trach mask. I don't want to set back his weaning process, but I can't ignore the possibility of bone infection and if not being monitored and him being taken off antibiotics too early. How should I best ask for both to be addressed? All of this is complicated by this facility refusing to give me doctor's orders, progress notes, and nurse's notes. My mother and I are supposed to be satisfied with the nurse explaining to us verbally if they have the time. I have asked for the notes and offered to pay. They have updated me that if I pay for the pages, I can have a printout, but it will be weeks afterwards. Right. That is ridiculous, and it sounds very similar to the email before. So, look, an infected wound is no fun. Now, I tend to agree that the more often you change the dressing, you might actually disturb wound healing. But there are dressings now where, you can keep them up to 7 days as long as they're waterproof and you can keep them on there for 7 days and you won't disturb wound healing. If anything, you foster wound healing by leaving it alone. So, again, but this requires a wound care specialist and it might require a wound care nurse. Okay. Again, you don't want your dad to be taken off the antibiotics for his bone infection too early. Definitely not. Right. So it needs to be, the antibiotics need to keep going in for for as long as the doctor's order is valid for. And once again, if your dad can be weaned off the ventilator, that is a good thing. Definitely keep doing that. I guess the issue there is, does he, God forbid, need a foot amputation? That would be really bad. Okay, so let's get to the next question. That is also from this client. Okay, and the client says, I have included my dad's online medical records account, which should shine light on his condition. Please click on stays at such and such hospital. I'm not going to mention any names. My dad doesn't have an online medical chart at Kindred, nor does any other patient. Well, that's interesting. My dad doesn't have an online medical chart at Kindred. Well, we have reviewed medical records from Kindred. I can't believe that they wouldn't have access to medical records. Find that hard to believe. My dad transferred here on the 9th of January. He was not on a ventilator then, and his lungs had not been a huge concern. He did have a nasal cannula with a small amount of additional oxygen being provided. The heel wound is stage 4, very serious right foot. His left foot had been stage 4, but was treated with surgery and prolonged home wound care and now has a skin graft. Yes, offloading boots, but current wound care has removed them and pillow being used instead. He has been bedridden for 6 months and while intubated with a ventilator for 3 weeks, couldn't receive physical therapy or occupational therapy. I call nonsense there straight away. There's no reason why a patient, even ventilated, even intubated, cannot be mobilized unless they are hemodynamically stable, right? Unless they have fractures, right? There is nothing that stops a patient from being mobilized. During his hospital stays, he acquired MRSA, which spread through his blood and caused endocarditis, which was treated with IV antibiotics. His white cell count was very high. He's currently not sedated and was either not sedated or on low dose most days while he was intubated with ventilation before the tracheostomy, mouthing words, squeezing our hands, spelling sentences by pointing to the letters on a chart. He's conscious and communicating, mouthing words, gesturing. The communication chart has disappeared and we have asked for a new one. He has a foot ankle specialist coming to see him on Friday. He is fed through a nasogastric tube. Right. So, well, that's definitely progress. He's, spelling words. That's really good. That is really good. Okay, so let's move on to the next question. Now, if you have any questions in the meantime, type them into the chat pad or join me live on the StreamYard link here. You can talk to me directly. Yes, I had a very interesting email this week that I want to quickly talk about from Tori, who says, "Hi Patrick, how do I forgive myself if the hospital made the decision to remove life support from a loved one and I regret so much that they did? I wanted to get the loved one back home and I felt they were improving. They are gone. How do I forgive myself when I feel they could have survived, my family member could have survived? I didn't want life support removed. The patient had a cardiac arrest and was very slow to wake up." Okay, that is very sad, Tori. It's a very sad situation, but it is what it is. You didn't know any better at the time, and going forward, you know where you went wrong, and I'm sure you won't go wrong again, right? You will learn from your mistakes. But this email in particular shows me that I keep saying that if you're in a situation like that where ICUs want to force you to make decisions and so forth, always approach it with, make decisions today that you don't regret in 12 months, 24 months time, because this is exactly what's happening here. Tori cannot live with the decision that she made, and that is terrible. But that's also why you need to take your time to make decisions. You can't rush life or death decisions, because that's what they are. They are life or death decisions, and you can't rush them, right? You cannot rush those decisions. Very simple, right? And when you give in to having your loved one taking off life support, know that there's no return from that. You have to be 100% confident that that's the right decision. If you're not feeling confident, you then need to wait, and you need to ask for alternative treatment, and you need to ask for a second opinion, right? You need to ask for a second opinion. You can't be rushing things. You are in a once-in-a-lifetime situation that you simply can't afford to get wrong, right? Why would you rush killing someone? Why? Where's the urgency? How many of you watching this, have had a loved one in ICU and you've been told from day one, oh, we should just stop everything? Many people, because we have numerous people contacting us every week with a similar question. Right? You have to question everything, and you also have to take responsibility. You have to take full responsibility. Full responsibility. Right? Never ever rush decision making in ICU in particular. Never ever. All right, so I hope that answers your question, Tori. If you have any questions, before I move on to the next one, if you have any questions, type your questions into the chat pad, or join me live on the StreamYard link here. I have got the StreamYard link copied and pasted into the chat pad here. All right, now let's move on to the next question. From George, who says, hi Patrick, my brother is currently in an induced coma. He was tased by the police on May the 22nd. He has an anoxic brain injury and the hospital wants to discharge him. Please, if you can offer me some advice, I would greatly appreciate it. Well, let the hospital not discharge him. Very simple, right? I guess you haven't given me a lot of information here to really guide you, but if you don't want your brother to be discharged, don't let them discharge him. Very, very simple, right? Hospital can't discharge from ICU without your consent, especially if discharge is questionable, right? I'm not saying that if someone is ready to leave a hospital and they can go home because they're well enough, there's probably not a proper argument. But if your brother has just come off ventilation, he shouldn't go anywhere. He shouldn't go anywhere. Okay, let's move on to the next question. And this question comes from Anna. Anna says, hi Patrick. There are two things I'm looking for assistance with at the moment. Number one, independent private medical assessment that may help either disprove that a discharge would be safe and or that my father still requires an acute level of care which requires a hospital. Number two, cost and process of an independent medical record review that might end up being used in court litigation. Well, Anna, we can do both. We have done independent nursing assessments that have helped our clients to go back, for example, from LTAC to ICU, right? Or that a discharge would be safe. Well, again, we have also done these assessments by preventing patients from going to ICU to LTAC prematurely. I mean, I'm opposed to LTAC all the way along, but, you know, that's certainly something we can do and we have done, right? Especially if you think that your father still requires the acute level of care, right? So, and then the cost and process of an independent medical record review that might end up being used in court for litigation. So, we've done that. You know, we have legal nurse consultants on our books that are critical care trained, right? So we have done those nursing assessments that can be used in court for litigation. So I urge you to reach out to us. You know, you can go to intensivecarehotline.com. If you want to call us on one of the numbers on the top of our website, or if you want to, you know, just shoot us an email to support@intensivecarehotline.com. Share the medical records ideally, then we can help you there. But these are all things that are in our wheelhouse, so to speak, right? We're also doing nursing assessments here in Australia for NDIS, you know, to advocate with funding. right, to advocate with funding, and we can do the same here, right? That is part of our areas of expertise, right? And the reality is, and we're also doing medical record reviews after intensive care, and it's such a shame that it should never come to that we need to dig down later what's really happened in ICU, because it's not a good thing. You should be managing things while they are acute in ICU. You shouldn't be trying to manage them afterwards, right? And this is why I think, and I'm saying it's so important that you take responsibility, that you do your research from day one. You can't just leave things up to chance. It's dangerous. It is absolutely dangerous. Okay, let's get on to the next question from Jakala. Jakala says, "Hi Patrick, I have a family member who went into hospital because her ankles were swollen. 2 days later, she's in ICU. She's a heavy drinker as well. She has been responding well, and all her vitals are normal, and her swelling has gone down. She has been opening her eyes a lot more since they have reduced her medication. She has even been trying to get up, but she's not following the commands or squeeze my hands and wiggle your fingers or toes. She's trying to get up all the time, but she's not following their commands, so she is still on the ventilator. Why is this? What can we do?" Excuse me. That is a great question. So, if her ankles were swollen and she's a heavy drinker, there's a good chance that she might have liver failure. She might have a cirrhotic liver. Her LFT, so liver function, might be off. That can lead to swollen ankles. But what can also lead to swollen ankles is heart failure. Maybe there's a combination of both. I don't know. Now, they have reduced her sedation probably. So she's opening her eyes. She's on a ventilator. She's been trying to get up, but she's not following the commands yet. Well, those are good signs that she's trying to get up. Just needs to be safe. The question here is this: can they reduce her sedation and opiates to the point where she can obey commands, where she can breathe up so that she can breathe normally, and then extubate her, right? So why is this? So when someone goes on a ventilator with a breathing tube, they often need to be put into an induced coma, right? When they're put in an induced coma, right, they are going on sedation and opiates, right? Then you stabilize ventilation, then you try to wean them off the ventilator, then you take them off sedation and opiates, and they may not wake up, right? Also, if your family member is a drinker, they might also go through withdrawal. They might go through withdrawal from alcohol, which then also makes it difficult to wean her off and wake her up, right? Once she's squeezing fingers, once she's wiggling her toes, once she's poking out her tongue by you asking her, once she's breathing spontaneously on the ventilator with minimal support, that's when you can look at extubation. Once chest x-ray is clear, once arterial blood gases are clear, that's when you can get things going, right? And again, if she's trying to get up all the time, again, that's not a bad sign, but she's probably just not there yet. So just probably needs a few more attempts, right? What can you do? Be there for her, ask all the right questions, get access to the medical records, making sure nothing's missed. Make sure it's transparent. Make sure they are not, they're telling you all the right things, and it's transparent. So I hope that answers your question, Jakala. Now we probably have time for one more question before I'm going to wrap this up. But also, if you like my videos, click the like button, subscribe to my YouTube channel, share the video with your friends and families. I'd appreciate that. And also with intensive care at home, like I said, we are currently operating all around Australia with intensive care at home, in all major capital cities, in all regional and rural areas. We are sending our critical care nurses into the home 24 hours a day to provide a genuine alternative to a long-term stay in intensive care. We are employing hundreds of years of intensive care nursing experience in the community. That is unmatched in Australia in 2024. We are the only service provider in Australia that has third-party accreditation for intensive care at home, right? We provide home care services for long-term ventilation, tracheostomy, BiPAP, CPAP ventilation, tracheostomy care when adults and children are not ventilated, home TPN, home IV potassium infusion, home IV magnesium infusion, palliative care, ventilation weaning, but also we're sending our critical care nurses into the home to provide emergency department bypass services. We change nasogastric tubes at home, SPCs, IDCs, tracheostomy tubes, PEG tubes, even casts, right? We are changing. So those are all things that are well aligned with us. We're also providing level 2 and level 3 NDIS support coordination. We're also providing NDIS nursing assessments, right? So there's so many things we are doing with intensive care at home. Please reach out to us. And if you're an NDIS support coordinator watching this and you're looking for nursing care for your NDIS participants, or if you're looking for more funding, you don't know how to get funding for nursing care, please reach out to us. We can help you with that. Right. Now, also, we have a membership for families of critically ill patients in intensive care, and you can become a member if you go to intensivecarehotline.com. If you click on the membership link, or if you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. In the membership, you also have exclusive access to 21 ebooks and 21 videos that I have personally written and recorded, and that will help you to make informed decisions, have peace of mind, control, power and influence, making sure your loved one gets best care and treatment, and so that you can influence decision making fast. I also do one-on-one consulting and advocacy over the phone, Zoom, WhatsApp, Skype, whichever medium works best for you. I talk to you and your families directly. I talk to doctors and nurses directly. And, I ask all the questions when I talk to the doctors and nurses directly that you haven't even considered asking, but must be asked when you have a loved one critically ill in intensive care. I also represent you in family meetings with intensive care teams, and once again, we've turned many situations around in family meetings by asking the right questions and by holding intensive care teams to account. We also do medical record reviews in real time so that you can get a second opinion in real time. We also do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. And all of that you get consulting advocacy at intensivecarehotline.com, or intensive care at home. If you need nursing care, you get at intensivecareathome.com. Contact us there. And for intensive care at home, if you're in the US or in the UK, please reach out to us, and we can help you in the US and the UK privately. So I'm going to wrap this up in a minute. Thank you so much for watching. Thank you for coming onto the show. I'll do these YouTube lives once a week, usually on a Sunday morning, 10:30 a.m. Sydney, Melbourne time, which currently is 8:30 p.m. Eastern Standard Time on a Saturday night in the US, which is 5:30 p.m. Pacific time. Currently, it is 1:30 a.m. in the UK on a Sunday morning when I do these YouTube lives, but you can also watch them on replay, of course. If you want any questions answered on these YouTube lives, just email them to support@intensivecarehotline.com, and then we can go from there. Thank you so much for watching. This is Patrick Hutzel from intensivecareathome.com and intensivecarehotline.com, and I'll see you again during the week. Take care for now.